For those of you that I haven't met yet, my name is Greg Gallo. I run the life sciences practice at Activate Networks. And hopefully you've enjoyed the morning session, and there's several sessions this afternoon that I think are going to rise to the occasion, meeting of your expectations to get some thoughtful, thought-provoking information to you. And to that end, this session right now is the first of two sessions that we're really excited about because they're highlighting the evidence that applying network-informed strategies can yield better results. Sort of if you think about what we've talked about so far this morning is sort of the fact that influence is at work, that it's happening, that it can be measured and it can be quantified. What we haven't shown yet, and what we're going to be doing next in these next two sessions, is actually showing you outcomes of where folks have now taken that data, incorporated it into their business plans, and obviously now measured the outcome and looking for the return for leveraging this new strategy, this new information, this new insight to better commercialization outcomes. So we're excited about it. The first is actually being done with one of our partners, Rivermark, who's also one of the sponsors of our conference, and we're really appreciative of the work we do with them, the partnership, and certainly the friendship and camaraderie. Leading the presentation is John Eichert, who is a marketing and sales strategist with almost 4 decades of sales and marketing experience and expertise in pharmaceuticals, biotech, and medical devices. He's one of the 2 principals of Rivermark and is also a senior fellow, at the Thomas Jefferson School of Population Health in Philly. He's worked extensively with academic experts and major global pharmaceutical companies to understand the impact of physician informal networks on the rate of new product adoption. He's going to share some data that does demonstrate this concept of a network-informed strategy improving commercial outcomes. So it's very powerful stuff. We're appreciative that you guys are here, and thanks also for your support and collaboration.
Thank you, Greg.
There we go.
Thank you. We've been working with network analysis since 2004, and our good friend Tom Valente is here. We've been working with him early on in some of these concepts that you're about to see. Our clients typically want to know, do networks really matter? If they market or sell or teach in a network fashion, does it actually influence the rate of an adoption of product? They also want to know, do leaders impact the network? So they know they can impact the behavior of the leader, but does the behavior translate from the leader to their network and therefore create a cascade? And if I direct resources to leaders, can I disproportionately invest in leaders? Can I accelerate the rate of adoption? So we're going to show you some case study. A case study specifically shows you the impact that leaders can have on the adoption of a new product. If we look at the current environment for commercialization, we, in our opinion, still see the traditional reach and frequency model predominate. High-volume prescribers get a disproportionate amount of resource than anyone else. So they buy high-volume prescribing lists from IMS or Wolters Kluwer. They might even go high-volume on patients through claims data, and they allocate resources based upon that fact. All companies can buy the exact same data, so they're all building strategy around the exact same information. So it's hard to differentiate. Yet the industry is addicted to this reach and frequency to high-volume prescribing model. We see limited innovation, although I think every company that we go into has a skunk works that's supposed to develop the new go-to-market strategy. I don't think there's one company we've gone to that hasn't had a group of people off working on figuring out how do we change our commercial model. But it hasn't really integrated itself into the organization. There is growing interest in network science. We get a lot of inquiries about it. Companies invest in the data. They learn about networks, but invariably their ability to implement network data is very low. So what they end up doing is taking network insights, network data, and they homogenizing it back to the reach and frequency model. So they take away all the network insights and all the network data just so it can fit into the Salesforce model, high volume sales calls on high volume prescribers. So we're going to show you some evidence, we think, that doing it differently actually can have an impact on the rate of adoption. Now, we do this largely because we want to make sure that the leaders we identify are leaders that really matter. So if I go to a client and say, here are the people we think are important, we have a high degree of confidence that those are the right people. So the last point is data silos inhibit better understanding of the impact that leaders and networks have on the rate of product adoption. So what we've been doing, and there won't be a lot of time at the end of the talk since it's a short talk, to show you how do you bring lots of data together around networks so you can understand what the networks are doing, what the leaders are doing, and what the impact leader behavior is on the networks. And as importantly, what's the impact of your resource allocation against those networks? Are you being successful or not? So do peer-nominated, I should qualify, the leaders that we are talking about here are peer-nominated leaders that are identified through survey techniques. We ask very specific questions. One's a trust question, and one's an advice question. And there's a third question we ask is largely based upon prominence and how famous somebody is. And we certainly learned that famous physicians are not always the one that I talk to, nor are they the ones that I go to for advice. So we differentiate and segment leaders based upon trust, advice, and fame. So the leaders we're going to talk about are the trust and advice leaders. So these are individuals who are nominated by their peers as someone they talk to and someone that they go to for advice. They could be different, but we do look, in this case, we're looking at those two relationships together. I should emphasize that all network maps are not the same. So it's important for you to understand when you look at a network map, what is the relationship that's being defined by the network map. So in this case, we're looking at trust and advice in defining leaders. And we think those two relationships are important to how physicians learn about new innovations. So I wanted to first show you a case study. This is a new antiviral drug for HIV. And this particular client did sociometric research to identify leaders. And they wanted to see, were the leaders adopting at a higher rate than their target physicians? So in this particular launch, we see that this company was very successful getting sociometric leaders to adopt early and at a higher rate than their base target population. So hold on to that, because the next slide shows, because what we wanted to know is, does the leader behavior actually translate to their networks? So if I can get that to happen, will their networks follow that same behavior?
What's the definition of adoption?
3 months continuous use of a product. So a trial might be 1 month's use. We looked at 3 months. So if they used it 1 month and they kept using it for 2 sequential months after that, we define that as an adoption. It's a good question because it's often a difficult thing to define. So then we looked at trial rate for all physicians in networks where the leader adopted the product, and that's the red line. And we compared that to the trial rate for physicians connected to the leader who did not try the product or did not adopt the product. So we can see there's a big difference in this particular case between networks where the leaders adopted the product and networks where the leader didn't adopt the product. That has some pretty profound implications. Now, what we don't know in this particular case is we don't know what the message was. We don't know, and this happened to be a fairly differentiated product, so we know that this product added incremental value to the existing treatment. So it wasn't a Me Too product. This drug added value to the treatment regimen. This might be different if a drug is a Me Too, 5th, 6th, 7th in the market, no differentiation at all. We are in the process of looking at those kinds of, that kind of data as well. This has pretty profound impact, but it also says, how do I intervene to look at the blue line and get it closer to the red line? That make sense? So the other thing we looked at is, did this company invest disproportionately in leaders? And in this case, they did. If you look at the left hand, the leaders who adopted had 65 resources allocated to them for that person. So when I say resources allocated, it could be a sales call, an e-detail, a voucher, a coupon, attendance at a speaking event. What we measured and what we were able to measure is only the data that the client had that they could give us that could be integrated into the network data. So there are things that happen that we don't have data for because they don't capture it and it's not a data feed that we can match to individual physicians. So there is certain limitations. So there may have been more interactions that are not captured by that number. But I think the sheer looking at the 65 versus the 20 tells us that in this particular case, it makes sense to invest resources in sociometrically identified trust and advice leaders. But that shouldn't really be the end of it. Companies spend a lot of money on speaking engagements. So they engage physicians to act as speakers and advocates. They walk around with slide decks. They have dinner programs, lunch programs, breakfast programs. They have online webinars. And what we wanted to know is, does it make sense? Is there an incremental value in matching network-connected physicians to the speaker? So in this case, the speaker was a leader. And we wanted to see, is there added value in making sure that in the audience is at least one member of their network? And what we saw is a fairly significant increase in the return on investment. We looked at prescribing after the event of the whole group that attended the program. And even if one person attended the program that was connected to the speaker, we got a pretty good increase in return in terms of post-program prescribing. This shows if you had two or more, you had even more impact. So what we're seeing is some value in making sure that you put the right speaker in front of the right people. And that often takes into account geography and network sphere of influence. So many companies take a leader or speaker and they put them in a geography where they don't have network connections and don't have influence. Yes?
How long was that impact? Or when did you measure the impact? Did you measure it after, but for how long was the duration?
6 months post-program.
Okay, so.
Yeah. We wanted to at least give it 3 months to see if we saw the adoption take place, and we carried it out 6 months. We continually track this by looking at, through these data feeds and integrating it with the network data. And what we've been doing lately is working with Activate to integrate the shared patient data into the peer nomination data. And what we're finding is a tremendous complement between the two data sets because surveys identify different type of leader than shared patient data does. And it often adds a segmentation ability that you're not able to do with shared patient data. But there's so much shared patient data that it's a great way to sort of populate and fill out the networks that we're not able to do by surveys. There are limitations to surveys. Largely, there is an investment you have to make in paying physicians to respond, and it takes a certain amount of time, and there's a limited response rate. Our response rates are between 12 and 25% on our studies. Yes?
So you're saying that for the last cohort, within 6 months, their prescription actually doubled.
Yes.
Pretty huge jump.
Yes. That's making sure that you've got the right people in the audience and using network data to orchestrate that. Making sure, right now what happens, I won't say in every company, but it's the sales rep's decision. So the sales rep decides who the speaker is, where the speaker goes, and who they're going to invite. The sales reps generally are a very poor judge of leadership and influence. We find about a 50% match rate between who sales reps believe are leaders and who physicians nominate. So there's a very poor correlation between sales rep point of view and physician point of view. Our data is coming from the physician, so we're not making it up. but there is a poor overlap between those two data sets. We also find some interesting combinations with the Activate shared patient data is that we're able, through surveys, to identify people that are not in claims data. There are a lot of physicians in certain settings where their data is not there. And so it's important to be able to combine the two approaches to make sure you get a complete picture. And the other thing that we've been finding is that if you look at author networks, who publishes with whom, leaders and networks and publications is quite different than peer nomination networks, as well as if you look at organizational leaders and organizational networks, which organizations are connected to which other organizations, and which leaders are connected across organizations. That too is somewhat of a unique network that has an impact on product adoption. So you have to look at sort of the domain of leadership, what part of the product adoption process are they affecting, and how do you engage them, and how do you optimize where they have leadership position. So we had asked Raghu, Christoph, and Tom to analyze some of our data. And this is a paper in Marketing Science about a year ago it was published. It's a tremendous paper, and it really convinced us that the data we're capturing actually does have value when it comes to identifying people that influence the rate of adoption of products. And one of the analyses they ran, and this was something I think the academic people decided to do, is they wanted to sort of model, what if we were able to increase the network influence of the top 3 leaders? So if we could double the network influence of the top 3 leaders, what would that equate to in terms of sales calls? So this is a pretty powerful quote, that the cost of having the top 3 leaders double that effective network influence is the same as the cost of 1 additional detail to 185 physicians. That's a pretty powerful multiplier effect that you can have if you can orchestrate a network approach to the marketing and commercialization process. I should say commercial process because it's not just sales and marketing. It's medical, it's clinical research, it's medical education. This network science can be used across the whole product life cycle. To really understand the power of what lies in the network map is you need to integrate in each one of those nodes a full range of data to fully understand what does that network actually mean, and what can I learn by it, and how can I track it and use it as a way of determining how well I'm doing. So in addition to some of the basic information, integrating managed care affiliation and prescribing data, referral networks are often quite different than trust and advice networks. Looking at patient demographics, how often are they being called on by sales reps? Are they a company speaker or not? What type of leader are they? Are they national, regional, or local? What type of leader category are they? Are they a prominent leader, an advice leader, or a discussion leader? All of that data integrated with a network allows you to really see what's going on. So here's a software package. I wanted to show you a screenshot to give you some idea what you might want to do. In this particular case, Namid is a leader, and that's his network. And we can track what's going on with Namid and his network over time. And one of the things you see there is there's a growing gap between the leader and the network. And there's some trends going on. So one idea is to take a look at the network map, see who's connected to Namid. In this case, he happens to be a speaker. And you can then generate a list of potential attendees who make up those network members and take a look at who might be good candidates to listen to Namid and understand how it is he's using this product. And what is it that he can learn, the network can learn from that person. Trust is a powerful tool for convincing people to do something different. I think it's really the fundamental tool, the fundamental relationship that really drives what people do. So what we're seeing is a movement from a traditional focus on high volume prescribers with a reach and frequency focus, looking at individual behavior and individual events, and moving to a leadership and influence, plus the prescription behavior. Prescription behavior still is what you're interested in doing. And this could be prescription or sales of any kind. Look at creating contagion, not just calling on one person. Looking at network behavior versus individual behavior, and build cascading campaigns, not just events. How many dinner meetings did we have? How many sales calls did we make? That's an individual event that you count. And then from a sales point of view, is targeting driven by RX is where it is now. Reps select a speaker. The audience is selected randomly. All the resources go to high volume prescribers. And there's a pretty uniform message that goes out to everybody. What we're suggesting is you should target by influence. You let customers identify who it is they want to learn from, who is it that they trust, who is it they go to for advice. You want to match the audience to the leader. You want leader-specific resources, so do something different with leaders. Don't give the leaders the same thing you give everybody else. The same thing with leader-specific messages and sequence calls to take a look at the network and take advantage of that network effect. So the company that launched that HIV product disproportionately invested in leaders, and they made an effort to connect the leaders with the network as early in the product adoption cycle as they could. In that case, they started it pre-launch with education, and they continued it on post-launch through promotion. So with that, I'll wrap it up and see what questions we have.
We had a couple sort of interspersed anymore. We've got time.
Yes?
I was intrigued that there was an increasing gap between the leader and the followers through time. I would expect that to have narrowed rather than increased. What causes the difference?
Leaders don't often know they're leaders, because they don't often know that their peers look to them as leaders. And oftentimes, their behavior becomes invisible to their networks. So the more you can create visibility between what the leader thinks is doing and believes, the more likely that'll start to close. It also works in the opposite effect when the leader behavior starts to decline and they switch from product A to product B. That could be an early indicator. If I'm product A and product B is taking share away and I see the leaders losing, you might want to take a look at how can I preserve the member behavior as long as possible, expecting I may not have a clinical advantage for the product. So, yes.
I'm going to add another group which nobody seems to be touching on, but they have a big influence, or at least they should have a big influence. The medical scientific liaisons, which are really not sales, they're medical.
Yeah.
How are you integrating that into the system, and how might this, that's a sort of an untapped area that I haven't seen anybody talk about.
What you would do differently between the medical department, medical science liaisons, is you in essence have to eliminate the commercial data. These networks are not commercially defined. We don't define networks based upon products or chemical compounds. We define them based upon disease and treatment of the disease or a specific subset of disease. We don't say, who would you talk to, who would you go to for advice about a new ACE inhibitor for the treatment? We don't do that. So take the commercial data out. Now I've told you who physicians look to learn from. So we had a client characterize our networks as learning groups. So these are groups of people that learn from each other, and there's certain physicians that have an impact. From a medical education point of view, if you just want to teach education, it's the same idea. It's an innovation. It's an idea that needs to be diffused through the network. From a marketing point of view, you would hope that that medical message is connected to the product message, but you can still accelerate diffusion of the medical message the same way I would diffuse the product adoption. As a matter of fact, you might have less restrictions on it because managed care may not be a factor with just pure education.
I think the other advantage that I would add, John spoke to it earlier, Dr. Valenti mentioned it in his lecture earlier, is you can tune the analysis for the application with
Yeah.
the network science approach. So MSL, meetings and events, some of those things, how either of our companies, you know, we're fellow travelers, but how you would tune and modify for that type of targeting would be different, for example, than what you might do for a coupon program or for pure rep education. The beauty of it is you've got the same baseline that you're working from, sort of the same data set, the same common assumptions, so that as you think about in a pharma company where you've got different silos, different people have different responsibilities, the ability to apply the findings off that common set becomes very, very valuable. So you're not into, well, that was you know, done by one group, they're looking at the world a different way, et cetera. Here you have an opportunity to look at the same underlying data and just tune the analysis, change the algorithm or the metrics a little bit different for the same for differing applications.
Because I see that as an important factor, because in many cases I've seen where the MSL sort of are lost. I mean, they're
Yes.
not really identifying appropriate their friends, their academic institutions, and they might not necessarily be the right people. And not that their things are measured, their outcomes are measured differently.
Yes.
But they still need to have the same impact.
And the ability to impact, the ability to be as efficient as possible. Some of them really know some things really well about their sort of span of control. As John mentioned, there's a lot that they don't know. And this is a way to systematize and broaden that. So, one more?
I don't know if this is your specialty. We're talking about pharma products for the most part. Have you been looking at diseases? Have you been also looking at information technology and how much physicians impact buying behavior or
Right.
on a hospital administration?
We haven't in our firm. I know that there's been work in the adoption of electronic health records and using network science to accelerate the adoption of electronic health records. We have not done that, but it would be very, very similar to what we've shown you. Because I'm sure there are specific individuals within physician networks who are early adopters, who know what it's all about. They've eliminated a lot of the risk. They've figured out the problems, and they become resources for everybody else. Concept would be the same, yes. Yeah. Yeah. Different set of questions, yeah, because you're asking about a different topic. The topic's different. The other important thing it is topic specific, so how you phrase the question is critical. You know, if I phrase a question that's so generic that no one ever seeks advice for the treatment of a common cold, for example, is there some subset that you need to ask about? That's important, that physicians do get advice about or do talk about. So certain topics are more active and there's more advice seeking in cancer treatments than there is in type 2 diabetes, as an example.
We'll take one more.
Yeah.
What do you think about network effects in geographies where there might be no doctors? And how does that impact the strategies or even tactics that you have in that geography if you
Eliminate the sales rep.
Yeah.
Companies either call that just no access or white space. And the power of networks is I can still orchestrate a range of network-driven interventions and campaigns without the sales rep. And by understanding the network, I can also see if a key influencer or key physician is in a no-access environment and I know who's connected to them, I might be able to see those around that person to try to create enough interest for that person to take a message to the no-access doctor, in addition to looking at non-personal types of efforts to try to get a message to that person in that kind of environment. It's a big problem in this geography right here. There's closed environments.
Okay, everyone. Thanks very much, John.
Thanks.
Very much. Appreciate it.